Well, welcome everyone. This is an episode of the Pediatric Lounge is being taped live. And before we get started, I want to thank a few people. First of all, I'd like to thank Kerry for Adjuvant.Health, who has coordinated this event and is behind the scenes and makes this a success. Second, and equally, Dr. Kerry, the CEO of the Allied Physicians Group in Long Island, who has been kind enough to lend us her network and IT specialists to make this a reality. Then my good partner, Dr. George Rogu from RBK Pediatrics, and the audience that I think is listening to us, not only in the United States, but in Costa Rica, Colombia, Lima, and Spain. And then let me introduce to you our guest, who is one of my mentors, a dear friend of mine, who I've known for more than 3 decades. She was my attending at Michigan State University. Her CV is long, too long for me to go into details, but I will tell you that she was an excellent community pediatrician for over 30 years at Rambling Road Pediatrics, so much so that those of you young in the audience will not know. But she used to send the patients with their spinal fluid and their urine in a paper bag for us residents to do the workup. She then went on to lead the health system in Bronson Methodist Hospitals, a children's hospital in Southwest Virginia. It is a community-based program, but it serves all of Southwest Michigan, a lot of rural communities without pediatricians, and all the kids come to Kalamazoo for both community care and tertiary care. Then she went on to lead in the AAP, not only as the former president of the AAP Michigan chapter, but she's now the board member at the AAP board. In addition to that, her life passion has been mental health, incorporating mental health into the community pediatric office, suicide prevention, and she's a national expert on that topic. But what is most dear to me about Dr. Gaggino, or Leah, is the way she takes care of her families. And she taught us to take care of the families we take care of. She is like thousands and thousands of pediatricians in America every day doing the best job they can for the kids of America so that we have a future. And in particular, I'm personally dedicating this episode to Jimmy Flynn. Jimmy Flynn was our kid as we were all residents in Old John Street. And I hope Tom and Gail are listening, as Tom is a pediatric infectious disease specialist, and Leah was a pediatrician. And she helped us all take care of Jimmy. And she helped us at the end when we had nothing more to offer Jimmy and we had to let him go. And the lessons that Leah taught us as human beings, as pediatricians, as parents and uncles of Jimmy, are forever in my heart. And I have a debt of gratitude for Leah, and Tom and Gail are my heroes on forever. I want to show you a picture of Jimmy because I keep it in my heart. And this is where we used to live when we were interns. So to Jimmy, Leah, welcome to the show.
I didn't know that you were going to make me almost start crying in remembering that. And it was beautiful. Thank you so much. And thank you for so many kind words. And I think the debt of gratitude goes to Jimmy and to Gail and Tom, who taught me about how to love a child and to work tirelessly on their behalf. And, I think the magic is in the room. It's with our kids, it's with our families, and that's why we do this work. And it's a joy. There are lots of sorrows along the way, but there are very few professions where we have this privilege of such intimate moments. So thank you. That was really a lovely introduction.
Thank you. Why did you become a pediatrician, Leah?
I loved science, and I had a fabulous teacher in Rochester, Michigan, Mrs. Talley, and I had a class in physiology. And we spent a year dissecting a cat and learning about organ systems, and I loved it. I was fascinated mostly with, I think, the kidney, the renal system. I grabbed my attention. And so I thought I wanted to go into physiology. And Mrs. Talley one day said to me, "Have you ever thought about being a doctor?" And I said, that's a great idea. So I went to Michigan State University undergrad. I was a physiology major and pre-med. And along the way, I was kind of a hippie, and I had a friend who was a lay midwife, and I went on a bunch of deliveries with her. And I thought, I want to do home births, and that's what I'm going to do. And then I got to Kalamazoo and did my OB rotation. And after seeing a couple of things that were kind of touch and go, I thought, no, there's no way I want to do home births. That is not going to work for me. And a lot of obstetricians were, it was hard hours, not that pediatrics isn't, but it was when I got to my pediatric rotation that with Jake Weintraub, who was my mentor, that I just said, this feels like home. This is where I'm supposed to be. And so that was it for me.
That was a wonderful program. We're going to talk about integrating mental health into the community pediatrician's office because you have a lot of experience in that. Why is that important? How do we do it?
Well, I don't think that a moment can go by now that we are not hearing about the mental health crisis, but I think for all the pediatricians that are out there listening, that this isn't something new. We've been challenged with kids' emotional needs and the struggles of their families for as long as we've been in practice. Back in the day, because I'm older now, it was before we had medications like Prozac and SSRIs, and it was mostly Ritalin and tricyclics, which I never used for anything. People were still using Haldol and Mellaril. People may not even know what those are anymore, which is fine. But I think, over the years, it just was one of those things that it kept coming up. If you want to listen, people have emotional needs, and it just comes part and parcel. But it became apparent to me that I needed to learn more because I just didn't have much education other than learning about ADHD. So I did lots of conferences. I did the Reach Institute program, which is fabulous. I did a lot of training with Stephen Stahl's program, the NEI Global, which was also fabulous. And, it just got to be a passion. And one of my dear friends, Dr. Mark Sloan, was really one of the people that encouraged me the most. So it kind of fell into that. And I have a family history of a lot of mental health issues. And so I think part of that was partly a driving force. And I was particularly interested in eating disorders. And when I came to the practice, I was the only woman. So a lot of the adolescent girls came to me, and just kind of morphed from there. And if you're willing to talk about it, patients want to see you and tell their stories.
I have a couple of interesting thoughts on this. First of all, Mark Sloan scared me about taking care of ADHD because when I was in Kalamazoo, he had set up a clinic and he had all these things that he did for the kids. It was 1 day a week.
Mm-hmm.
He looked for learning disabilities, anxiety, depression. They had a teacher that saw the kids that were reading, and I'm like, I can't do that by myself. It's impossible. He was so great at it. I'm like, I can't do what Mark Sloan does.
I'm not sure anybody can do what Mark Sloan does, because Mark Sloan is brilliant and funny and creative and genius. But I learned a lot from him. For 6 months or a year, I spent a day a week with him just doing mental health care. But he was the first in our practice that was really doing mental health embedded in pediatrics. And I don't know, once I had the bug, it just went from there. And the need is huge. People's emotions are part and parcel of their being, and you just can't sever the two. Even if you try, it's there. So I think it's one of those things we just have to kind of step up. We just can't say I don't do mental health.
Yes. And then I was fascinated by the way you solve the problems. So one of the solutions that you had, because the money's always important, is that you partner with Western Michigan University with their PhD in psychology. And you had some phenomenal students rotating through your office, just like medical students. And they learned development, but they also taught you on the practice about mental health and pediatrics. Can you tell us how you got around to that? That's a fascinating story.
It was a fabulous solution that I cannot take ownership for. So I, full disclosure, see a therapist for anxiety disorder. And I was really having a hard time. At one point, I thought, you know what, I'm just going to do behavioral health medicine. But as you said, just doing that only, I couldn't afford it because you just can't see enough kids if you're doing it on an RVU basis. And so I was talking with her and she said, you should reach out to the psychology department and see if they can help you. So I did. And Dr. Galen Alesi was the head of the clinical psychology department. And what ended up happening was I had a student, Dr. Cheryl Lazowski, who's a psychologist, PhD psychologist, and she spent about a year and a half with me. And she was getting her clinical hours and I was getting her incredible expertise. And we developed an actual external practicum because they needed the hours. And so it was kind of I hate to use the phrase, but it works, win-win. They needed what I had to offer and I needed them. And it was literally, I had someone at the hip. So, and I had, over a period of time, I've had 10 students that went through, and many of them are at institutions across the country. And really integrated behavioral health was kind of a new thing. I learned a lot about it at Knoxville, Tennessee at Cherokee Health, where they were really kind of the leaders in doing integrated behavioral health. And so it just came to fruition. And eventually that program kind of, we finished that program, but at the same time, then we brought in social workers and put them in our primary care practices, doing similar things a little bit differently, but our system was willing to pay for us to have social work. But the thing about having the doctoral students was that was free. That was free to me. So for those that are out there, if you have a university nearby, you might think about reaching out to, there's counseling education programs, clinical psychology, and then also departments of social work. And, you have to work out agreements and there's some, ins and outs there, but it's important for them. And it's something that we can learn a lot from them. I've learned a lot of strategies, particularly like CBT that, I think primary care can actually do in short periods of time.
Leah, I have a question.
Yeah.
This is all fine for academic centers, systems, big places that are funded and monies are coming from elsewhere. Most of the people that are on this webinar tonight, they're general pediatricians just like me. They need to know how can they go about doing the right thing and make it, no margin, no mission.
Right.
It's nice, but it's not so easy.
So we're gonna have some panelists today. So for example, Susan Sirota has found a solution where, for lack of a better term, the psychologists are rented or embedded into the practice, but she's not responsible for their salaries. And Scott out in Kansas City, Missouri, they have 3 mental health providers, including a PhD in psychology. And they figured out a way of making money outside of the big health system and still doing the right thing for kids. So it's doable, not easy, but it definitely is easy. It is doable. And I think the solution of partnering with PhD students from a big university is a win-win for society and just very elegant. I really like that. So
The other thing I would just say to that, and George, I mean, I'm not in your shoes. I mean, I was an employed hospital physician my entire career. So I was never in private practice. So I'm not the expert in that. You are. What I can say is that, even we're not an academic center in terms of big university. We were affiliated with, but our university also has a large catchment area. So those folks could go out to a rural area that was, within a 30-mile radius. So I think if there is a university somewhere in your vicinity, it might be worth reaching out to. I think it's an option to consider. I never would have imagined that it could work for me. I just thought I was stuck, and we didn't have child psychiatry to rely on. So it was us.
And when you were implementing these programs, Leah, both at the practice level and at the health system level, because for 5 years you led the health system's mental health initiatives, what were your biggest pain points? What was it that you had to struggle the most to get people to understand how important this is for the future of our children?
Oh, I hate saying this. The hardest thing were the physicians. Honestly, this is just something that people have a really hard time with. I think owning that mental health is our job. And whether we feel well trained or, it's not what I went into medicine for. And I think the ship has passed. I just don't think we can use that as an excuse that we can't do this. I think the question is, how do we do it differently? And I've been thinking a lot about it in the context of COVID. Nobody knew anything about how to do COVID. And yet we didn't say, well, I don't do COVID. I don't take care of patients with COVID. No one had training on that, but we figured it out it's the best we could. And it was a crisis, is a crisis. And I think that we can apply that to mental health. It is what is killing our kids. Far and away, mental health disorders are the crisis that surpasses COVID. I mean, the second reason why kids die is suicide. The first reason is gun violence, whether it's unintentional or intentional. So our work is there. I mean, the disease of the day is not infectious disease in terms of what is the killer of kids, and the mental health issues. If we're going to care about kids, we just have to figure this out. And I think the first step is just owning it and accepting it. And that's a hard one. And I know that there are all kinds of reasons. I think the other pain point for me was leadership. Again, like we don't do mental health. They do it at the hospital across town. The hospital across town has the inpatient psychiatric unit. So we're not doing that at our hospital. But again, the child with cancer comes to the hospital with their anxiety and depression. You can't say, well, yeah, we'll just send them across town for that. So I think those were the two biggest challenges. And I still think it's a challenge to just say, this is what we need to do to respond to the needs of our children.
So I'm going to just interrupt you for a minute. Excuse me. And so Kalamazoo is a small town of about 100,000 persons, has a couple of universities. It has Western Michigan University. It now has its own medical school, and it has something called Kalamazoo College. And then it has, I think, a couple of community colleges. There's two large health systems, one called Bronson Methodist Hospital, which has a children's hospital embedded into it. And then it has another one called Borges, which is a Catholic hospital, which doesn't really provide a lot of pediatric care. And they kind of share some stuff. All the high-risk pregnancies go to Bronson, but the mental health goes to Borges. But there's always some competition between those, and they both have to do so. And Borges actually did own some pediatric practices even back in the day when I was an intern. What is a great a great mental health program within a pediatric practice look like, Leah?
Well, of course, the number one thing is to have an integrated behavioral health. I mean, for me, it changed my life. That and access to psychiatry, and in the form of, ideally, I think a lot of us wish we could send every kid that has a problem that we don't feel comfortable with to the specialist. But the Child Psychiatry Access Program, MC3, is what it's called here in Michigan. They're in every state except for 4 that are working on theirs right now. Saved me, changed how I practice medicine, because I could call and say, hey, I've got a kid who, this is what's going on. This is what I've tried, or should I try? And they would walk me through. They would hold my hand. They would send me documentation. And I could call as many times as I needed. And over time, I didn't need to call as much because I knew what to do. So having those relationships and making the effort and making the time to call those folks. I think having screening, routine screening, and we'll talk about that in a little bit, for especially suicide screening, but asking about depression, asking about anxiety, and having workflows that make your day not a huge mess, so that you're sort of anticipating this is how it can go, and working with your clinical staff. How do we take those calls? What do we do if a crisis calls happens? We don't, we know what to do. So at the end of the day, when a patient comes to us, the message that we convey to them is, I've got this. We talk about anxiety here. We can talk about your depression. Yes, we can talk about your suicidal ideation, because I have set up a system in my practice to manage that. And when I can't, or when it's hard, I have my partners to talk it over, and I can call the child psychiatrist. So, and I don't want to imply in any way that it's a perfect setup or that my day didn't get messed up, but it also would happen if I had a child that was a new onset diabetic, or a kid that came in with a bad asthmatic episode that took extra time. So yeah, I could go on for a long time about what that would look like, but I think I touched on most of it.
Yeah,
Yes.
I think most pediatricians already figured out the screenings, the work plans, the process, how to do it. As long as they're normal, everybody's good. But then comes the abnormal, and then what do you do with it? We had an integrated health, behavioral health program in our office, where we had a social worker embedded in our office. Something, the hospital system put her into our office. She was full immediately, 300 patients on a panel. And then they couldn't make it work. So they let it go and they shut it down.
Yeah.
Yeah.
And I think that's where we have to advocate with our payers, that this is essential to our practice and to our systems. There's a lot to be said for how you set up integrated behavioral health. If it's co-located care where they're doing therapy and they have their own panel of patients, it doesn't work as effectively as if they are doing brief interventions. I can pull them in for 15, 20 minutes, maybe half an hour. I go on. And so it goes throughout the day that they're being pulled in and out of rooms. That is the effective and kind of the ideal integrated behavioral health, but it takes some doing. And when we had our social workers, when they first came, we had 6 of them. They were assigned to 12 practices. Nobody knew what they were supposed to do. They didn't know, the docs didn't know. And so that was my job over 5 years, was to build that program. And there were lots of bumps in the road. I'm going to be totally honest with you. Those social workers looked at me with big eyes, like, we're going to do what? And, I just sort of said, well, this is what our goal is. We had a grant. So we had some money we had to spend. And so we said, this is what we're going to do. And that's how we move forward. But, doing brief interventions is very different than doing traditional therapy. And if you kind of go down that path, it'll eat up their time, just like you were saying, George. They won't be able to do the work that you need them to do. So it really is important how you set up the model.
So there's great things going on across the country, and that's why we like to get together from all over the country. So for example, I just got to touch on this for a second. You and Kerry produce children that are very involved in eating disorders. And then we have Jeanne Marconi, who for a very long time was in a primary care environment, a community pediatrician, and she embedded all the psychological help, not only the social worker, but the psychiatrist to help kids. And now she's with a group called Pediatrics across the country, and they're offering qualified therapists for quick interventions, as I understand it, to telemed, and they're going to embed them into their urgent cares. They're in 17 states for quick interventions, if I understand the program correctly. That was also tried at Rainbow Children's in Cleveland, and that significantly decreased the cost of taking care of Medicaid patients. So there are ways of doing this with, CEST and to help and not lose your shirt at it. And that's what we're here to discuss. And later we're going to discuss about suicide prevention, suicide screening, and how not to freak out when somebody says they're going to kill themselves, because the standard has changed. When someone told me they were going to kill themselves 20 years ago, they got admitted with a babysitter. And until psychiatry came in and said they're okay to go home, they weren't left to go home. That's changed. So I'm going to turn it over to Dr. Kerry, the CEO of Allied Physicians Group in Long Island, who is going to moderate our wonderful panel this afternoon. Thank you, Kerry. And how are you?
I am good. Thank you, Herb and George and Leah. I'm going to ask everybody to turn their cameras on, and we're going to take a moment just to have everybody introduce themselves. So tell us who you are, what type of practice you practice in, where in the country you are, and what you have done for mental health in your practice. So let's start with Scott.
I'm Scott Rogers. I'm from Kansas City, Missouri, and we have a private practice of 20 pediatricians now, and we started a mental health program about a decade ago and have built that to become a psychologist, plus now we just actually have 3 LCSWs. And we've been engaged in primary care with trying to broaden what our interests are from our various physicians. And that includes a wide scope of different interests, but mental health is something that we've been committed to for over half the amount of time that we've been in private practice, into something that, like you said earlier, Leah, we've learned some things through the hard way, but we've had a lot of successes, and glad to be here to help share some of those stories with you all tonight.
Thank you, Scott. Susan?
Hi, I'm Susan Sirota, and Herb and George, thank you for the opportunity to be on the panel. Leah, I really enjoy hearing what you've had to say and more from you. I practice in the north suburbs of Chicago. I'm an independent primary care pediatrician, and I practice in a large supergroup or group practice without walls called Pediatrust. We're a collection of what were 12 independent practices, and now together we're about 80 physicians, a couple nurse practitioners, and 20 sites, and we practice very much under a medical home model, and integrating mental health into our medical home was something that was a goal for us early on. So we integrated mental health into our practice in 2017, and we manage patients with mental health in a number of ways. All of our physicians are trained to treat things like anxiety, depression, and ADHD. We partnered with a practice called PCPA, or Primary Care Psychological Associates, and they are a practice that integrates their psychologists into primary care office settings. So it's not just a co-location, we're one team, we co-hire the psychologists that work for us. And for our 12 legacy practices, we have 6 psychologists who see our patients both in person in our offices and partner with us, also virtual, and for a time in the pandemic, entirely virtual. And so we have an opportunity to really provide that care quite easily for the vast majority of patients across our Pediatrust practice. What is really nice about having them truly integrated into our practice is that we share an EMR, so we have access to the same patient chart. We're physically in the same places many times. And so we can take time to talk about a patient. And we've had a lot of success with what we call a warm handoff in the office, whereby, and this is really good for the physician's mental health too, where when we get into a difficult situation and there is that pressure of, oh my goodness, I have so much more to do today and so many more patients, we can knock on the door of our psychologist, invite them into the exam room, tell them first a little bit about why we're inviting them in. They can take some time with the patients and then have a follow-up plan for when they'll see our mutual patient and spend more time with them. And our success with getting our patients to that care that they need has really been tremendous. So we went from probably about a 25% rate of patient follow through when we did not have integrated psychologists to something around 70 to 75% of our patients where we make a recommendation have follow through. So it's really led to improved health and has been, of course, instrumental in the pandemic. Our model is a short, relatively short model, problem focused, where patients are maybe having 5 to 8 sessions, gaining the skills that they need, CBT, CDT, then taking them and moving on and working on that, and then following up as needed, just like we would approach any other chronic health condition with our patients.
Okay, Susan, that was a good overview, and I have more questions, but we'll get to that in a little bit. Alisa, sorry.
Okay, thank you for having me. First of all, I'm Alisa Minkin. I'm a general pediatrician at Beach Pediatrics, which is in Oceanside and part of the Allied Physicians Group. We do not have integrated mental health in our practice. I'm here to learn from the rest of you and maybe complain a little. And also, I'm really honored to be here today with Leah Gaggino, whose podcast, Pediatric Meltdown, is a must for everybody who wants to learn about pediatric mental health. Every episode is amazing. I will say that I'm very passionate about mental health because I have an adult daughter on the autism spectrum with associated mental health problems. And I really believe that no matter what you know, you have to try your best to do the best for these kids. In our practice, I'm proud to say that we do routine screening. We do routine anxiety, depression, and suicide screening. And I learned about the importance of suicide screening from Leah's podcast. But I desperately wish we had some form of integrated behavioral health because it's so hard. I'm not going to say it's easy, and it's a constant struggle.
Thank you. Kristin?
Hi there. Thank you so much for having me. I'm Kristin Struble. I practice in Phoenix, Arizona at a group called Camelback Pediatrics, and it's been around forever, and I've been here, I feel like 50 years, but specifically in the last 3 years, just with the mental health crisis. I got on here late because my last patient was a teenager who was in for a well check. And we did our PHQ-9s, which is what we do to, just do the initial assessment. And of course, hers was sadly abnormal. So spent, go from our allotted time for our well care. And then you have to spend the time to deal with, that. And I definitely feel inept in terms of, managing depression and anxiety. I used to refer a lot of patients out just because I always thought with my kid, what would I want? And I always felt like you want to send them to a psychiatrist, but obviously we don't have that option anymore. But in a way, I feel like it's making me a better doctor because I feel like we definitely need to serve our patients in some capacity, even while we're trying to get them to a specialist. And I'm so excited to learn from you all. Leah's podcast has been absolutely amazing. And she spent some time talking to me privately, which was just very insightful and kind of calmed me down a little bit because I just want to do the best for these patients, like you were saying. And we, as pediatricians, we're thrown into, such a wide variety of what we're supposed to manage. And I feel like mental health is the most critical, the most ignored in the medical realm, as we all know. And I feel like I do want to do what's best for these kids. And so I thank you all for being here. And so what like I said, we start the PHQ-9 at 11, the routine screenings. But then we get a lot of phone calls, aside from that, just as you guys all are too, is asking to come in and chat. So, but anyways, thanks for having me.
Or actually, they just want to chat on the phone.
They do want to chat on the phone, and that's tough because you're like, okay, in the middle of me not, having lunch or using the restroom for the last 5 hours, and talking to a hospital with an admission for RSV. I don't know if and then somehow they get my cell phone number from friends of my son. I got one today, and I'm like, oh, how is that going to happen? But please call the office. So yeah, they just it's interesting, but it's tough. But I feel like, thank you, Herb, for doing this, and for you all setting this up. Obviously, George too, and you all allied. I know you guys put a lot into this, so excited to be here.
Thank you. And Jeannie, you have a checkered history to share with us.
Sort of, yeah, transition. So thank you everyone for being here. And I'm gonna steal one of George's phrases. It's really good to all be talking about this critical issue, and we're all part of the medical neighborhood in different ways. George, I think you've coined that word several times lately. So I think we all come from different perspectives, and I think there's a lot of gaps in care that we can all figure out how to meet together. So my sort of long story was in general practice for 20 plus years, and started behavioral health in my practice from the day I left residency, as a co-location model, but also as a new moms group run by a social worker to go over a lot of the challenges, sort of like after having a baby and living in the suburbs and not being near your sort of supportive family, to a fully integrated model that was recognized by PCMH, as a level 3 practice with distinction in behavioral health. So that team included a social worker, care manager, child psych APRN, developmental pediatrician, and then some others who had some expertise in ADD. So I must say, putting that model together and overseeing it was a huge amount of work. I won't say that it wasn't easy, and I won't say that we made a ton of money on it. We covered it, but we definitely did not make money on it. It's not a money maker, by no means a stretch of the imagination. But it really did provide a good service, comprehensive. We always knew what was going on with the patients. So collaboration is really key, I think, for families, including, the parents as well as the children. So we did include some parent groups, along the way. A couple of years ago, I left practice and joined PM Pediatrics to develop, implement, and sort of try to be innovative in meeting this gap in mental health. So we have a community model, which is, sort of the same kind of collaboration, and we're following the University of Washington collaborative care model. And if you don't know about it, I strongly suggest that you take a look at their site. They have tons of education. They talk about how to train a behavioral health care manager. They talk about how to actually put it together. It's really like a hand holding. It includes a care manager, therapist, psychologist, psychopharm, pediatricians, or others, APRNs who can write psychopharmacology, and then at the back end supporting the clinical team is a child psychiatrist. So we all know that there is a shortage, but for them to manage peripherally for a few hours a week and not bill the patient and just be supportive to you is really amazing. And then over the past year, we've taken that model, abbreviated, and done sort of what Susan's talking about, which is a brief intervention model in schools. So now we're in several large school districts across the country actually doing this work in schools where the kids are, especially meeting the lower socioeconomic class, which will not be able to reach these services. So a little different spin. Again, we are very collaborative with the pediatricians. We're not trying to compete with those that are doing behavioral health, but there's so many of us that aren't doing it or can't do it or don't want to do it or don't feel they were trained to do it. So again, just figuring out where the gaps are and trying to all hold hands together to wrap ourselves around it. So thank you.
Thank you, Jeannie. One of the viewers came up with the same question I did. Whenever we mention a resource, can we make sure that either it goes into the chat or we send it to Ari? Because we're going to send out the recording and it's going to come with an email, and we're going to have a list of all the resources that anybody mentions here. Okay? Okay. So, God, this is for you, because I must tell you that Allied's been trying for a long time to have social workers embedded. And we had one before the pandemic, who we lost during the pandemic. And we've had a job rec out for a while and haven't been able to fill it. And one of the major questions that got asked multiple times by the registration, when people registered, was, how do I get a social worker in my office? And how do I make it work financially? So I'm going to give that one to you.
Yeah, that's a brilliant question. We're fortunate because we've had a psychologist in our practice now for several years who's very well respected in the community and offers a lot of guidance and supervision for people that want to work alongside him. So Dr. Brown is his name, and he's been able to oversee and help kind of navigate who we recruit to our location. And there are actually a lot of LCSWs in the Kansas City area. And the fair answer is we're a large group and we feel really connected and networked to several programs throughout the Kansas City area. And that's allowed us to just grow in our attraction for people who want to come alongside and work with us. So with that being said, we are actually in a contract with the state of Missouri that helps us fund our health home, which also helps us afford not just one LCSW, but now we just hired a second one. So that significantly offsets our costs for being able to keep them salaried. With that said, we certainly don't, and I don't know if you want me to answer this necessarily, but we certainly don't make money on our mental health program. We have to make hard choices when it comes to providing the service. And for us, the question is, what is our why behind what we do? And we all have very strong whys. I can give a long testimony for my own personal reason, but when it comes down to it, the right thing to do is to meet a need that is, it's an epidemic across the United States. So with that said, we all recognize that we're probably going to take a little bit of a personal loss when it comes to, our gross income, but knowing that we are providing a service that makes, each of us more efficient in the office because we've got integrated social workers and psychologists in our office, that lets us be more efficient to make up income in other ways that are more strategic. So in the end, I don't feel like I'm losing anything financially. I just feel really good about trying to provide care that is thorough and meets the needs of a large patient population that would otherwise be unmet if we weren't all trying to learn this, on the job. I really appreciated Kristin and Alisa, you both saying that you're coming to this group to learn. The humility in that statement is really what defines us as a group, because even for myself, I don't consider myself an expert. I consider myself an expert at trying, and that's what we've been doing for years, is trying to do this right. So with that motivation, we've been able to carve in a financial direction that has let us survive. And, as part of the business hat that I wear, we navigate the budget every year, and there's always line items that come up that were like, can we afford to give our, nurses a cost of living increase? Can we continue to help pay for their insurance? Can we make the same amount of money that we made last year, that we made the year before that? And there's always these pain points where like, well, we could drop mental health, or, we could maybe stop seeing our Medicaid patients, and, maybe that would help make more money for the practice. But in the end, we're like, that just doesn't feel right. And we've continued to land on our whys as a motivation to say, we're just going to figure out a way to do it and not say no to anyone, but yes to what's right. So that's been motivating.
That's an amazing testimony of what's possible, right? And pediatricians are an amazing group. And I've, by the way, never heard anybody who said they wanted to make money on mental health. Most people are just hoping that they don't have to lose money. But that's why we're here to talk about the different models. And Scott, you mentioned, the mistakes that you made over time, or I may have put that in those words in your mouth, but the learning that you've done over the last few years. Leah, you mentioned the mistakes that you've made. Is there a resource for someone who's looking to do this? I know, Jeanne, you mentioned Washington. Leah, are there resources through the American Academy or something else? Like, if this is something that a practice wants to do, where they can have different options laid out for them and suggestions and ways that we don't have to make the same mistakes that you pioneers have made for us?
Well, I think everybody will have to make their own, you have your own stumbles. But before I say anything, I like feel the love here. I mean, the one thing I think that's really cool when I listen to Susan, I listen to Scott, it's like, like it's a relief to know that you have help. And for those of you who don't have that help, there's that angst and pressure, and it's so hard. So we have to figure out, as a group of pediatricians in the United States or wherever you practice in the world, how to do this so that we can all do our job. And Scott, I love what you said about, I do this because it's what I need to do, and we just figure it out. And again, I think, sort of like COVID, we slog through, we figure it out, and we do it together, and it's hard. This is hard work. But the other part of it is there is such joy in having successes. When you have kids that do well over time, that had problems with depression and they do well, or the kids with autism that you struggled with and they have jobs and drive and own a house, that's a gift. So, there's joy in the work too. So as far as things that you can, there are a lot of books on integrated behavioral health. And the one that comes to mind is it's Hunter and Gowdy, I believe, or Goody. I'll make sure that you have that, Herb. That's a whole manual on integrated behavioral health. And it has a lot of stuff on sort of what a brief intervention might look like. The AAP has lots of toolkits. There is one on ADHD, autism. So there's also something they have put together on mental health competencies. I'm happy to also work with a practice if you're like, gosh, this is what I'd like to do, to say, well, how can we do that? What would that look like? What do you want it to look like? And you're not going to be able to do it all at once. I'm sure Scott and Susan, when you guys started this, you didn't just go like from here to here and it was all like in perfect, you start with depression screening. You add in, are we going to do anxiety screening? What are we going to do with that? And you talk about that. So there are lots and lots of resources, but I think you have to sort of step back and go, okay, I don't know this, I probably learned from being in in administration, like what's our current state? Where are you right now? And what's your future state look like? What would it look like in perfect care? If you had a dream that you could do that, what would it look like for a patient to walk in? At the end of the day, you want those parents to feel like my pediatrician is here to help me. Like you said, Alisa, you have a daughter that has, the last thing you want to do is somebody to throw up their hands and say, well, I can't help you. I don't think anybody would say that, but I can't send them to the psychiatrist, so I'm sorry. So we have to figure this out together. And I do think that there are models. So, and I'll be happy to send some things. I also did a podcast with John Price and Ms. Vallejos, and she talked about their program in Virginia. It's a private practice, and how they actually did financially quite well doing things like group therapy. And she really worked with her payers. She did contract negotiations. Was very savvy. So they made it work. But, I think part of it is people are doing it individually. And I love this group conversation about, okay, what worked for you? Could I use that? Because I think that's what we have to have, these big conversations. This is a start.
So one of the questions was about the practicality of having somebody share your EMR. So Susan, I'm going to send this to you because you mentioned EMR. I know we're having a hard enough time figuring out privacy just for the adolescent well visit, right? The patient tells you that, they're questioning their sexuality, and how do I not share that with mom? What do you do about the EMR and your mental health visits?
So we have probably a bit of an advantage because we are on Epic in our practice. We're on a community instance of Epic through our children's hospital. So we're independent, but it's something that was offered to practices in the Chicago area. And so that's the EMR that we use. So our psychologists, like all of our clinical providers, access the chart through Epic. The notes are maybe not filled with all the details of what might occur or what might be discussed in the session. So the note really focuses more a little bit on the intercurrent history and then an assessment of how the patient's doing, because we also have the opportunity to speak directly to our psychologists who are seeing our patients. But Epic also has something that's called a confidential note. And I am under the impression that most EMRs have this, and if not, they probably will soon because of where we are with current laws and how that impacts EMR and sensitive information. But a confidential note is something that is not visible to the parent, not to the patient, not to anyone who has the routine access through open notes to the medical records. So anything that's sensitive but needs to be communicated is put into a confidential note in our EMR. So I think by nature of the design, that problem is handled fairly well. But we have, I want to emphasize, by having someone truly integrated in the practice, not just co-located, we have direct communication, and we have the opportunity for direct communication, including something called staff messaging through our electronic health record. And that is also something that's not shared through the open notes. So what I did want to add, sorry, Kerry, one other thing. We have a couple other things we do in part, and these might be options for smaller practices, individuals who want to take smaller steps. We have one of our nurse practitioners in our practice who took some time out and got mental health certified, a certification that's very similar to one of us doing some sort of fellowship training in pediatrics. And that's given her quite a level of expertise. So she has training to do some more detailed evaluations, for example, with autism. And when we're managing patients with medication and things become a little more complicated, she's able to help us with that as well. So that's someone who had worked with us for years, but went on to get that, was able to take some time out and get that training. And then we also are part of a collaboration with our children's hospital, Lurie Children's Hospital. And I think this is something also independent practices could set up if they have some sort of medical institution. And we have monthly meetings that cases are presented, discussed, and there's education around the topic. And then in addition, we have at all times access to a particular psychologist and psychiatrist who are part of this program from the Children's Hospital, so that if we have a patient who needs a more detailed evaluation than we can do, and or we want some assistance with medication, they get an evaluation through that program. So that's a collaboration program, and I know these can be set up with all sorts of mental health programs around the country. So just two options for people to think about.
Thank you, Susan. Jeannie, this one's going to go to you. Would like to know more on how providers are integrating mental health from school to home to the PCP. So I know you're not PCP anymore, but you are in the schools. How do you see that working?
So we, our embedded school health program is the 4 to 6 brief visits. That's probably the most common one that schools want. And we actually get permission from the parents to release that information to the pediatricians. So they get a note when we start this brief intervention. If there's an escalation or we think they need more ongoing treatment, we reach out to the pediatrician. Do you have it in-house? Do you want us to refer to the community resource? Our community program, we're still negotiating with insurances. We're probably there in maybe 2 or 3 weeks. So that's been a reduced cash model for that. So they can use that if they want to. The other way we do that in the community program, it's the same thing. We've established relationships with pediatric practices, and some of them preferentially now work with us. We also will work with pediatricians who want to write the medication, for example, but they don't have a way to do the therapy. We're willing to work that way. And that really helps a lot, because if we have someone else writing the medicine, we have more capacity to do more evaluations and the therapy. I think the more pediatricians write the medication and the more they interact with people that are doing it, the hope is that once that child maybe is stable, we can transfer them back to the pediatrician once they get comfortable. But what we're running into is a lot of pediatricians aren't interested in doing it. They just don't, they don't have capacity. They're busy doing other things. You know, it's too much on them. They're like, it takes too much out of us. You know, I think, you know, we're dealing with, you know, sort of the downdraft of burnout. So adding one more thing for them to do is just really, 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 really tough. The other resource I just wanted to share here, in addition to Susan, the child psychopharm listserv, where all the psychiatrists hang out, is an amazing listserv. You can put a case there. You learn every day on different modalities, ADHD, new medicines come out, like, and I'll share that listserv contact, but a lot of pediatricians are on that as well. And they really do give you lots of good information.
Is that an AAP listserv?
No, it's from the child psych group. So the CAP, Child Adolescent Psychiatry. So it's mostly child psychiatrists, psychologists are on there. And then there's a lot of pediatricians. So there's a lot of SOPM people on there. For those of you who know SOPM, it's just another listserv to dump out every day, but it's a nice resource to be able to reach out to if you have a question.
Great. So Alisa, this one's to you. Some of the pediatricians want to do more screening, but they find that the parents push back, right? I don't need to do this. Or why am I getting charged for this? Your intake form is too long anyway. I know our patients complain about freesia. I know you value screening. You're doing a lot of it. You're leading the effort at Allied for suicide screening, which we're going to talk about next. How do you deal with that?
Every practice is different. I know some people like to have it go in through the freesia or the teen cell phone. I'm tech phobic, so we do paper. And paper is easy because you just hand it to the teen, right? I haven't had a problem. I haven't even had a parent of an 11-year-old complain that we're giving a suicide screen to their young child. So we haven't had any problem with that. I can't tell you what to do about it because it hasn't been a problem. I think parents are really appreciating that we're looking at their kids' mental health and taking it seriously.
I think it may be very similar to vaccines, right? When you make a strong recommendation, the parents accept it. Like, here's this screen, fill it out, it's important. Kristin, I know you mentioned you do screening. Do you have a different experience?
So we do use freesia. And one thing that I noticed, even being a parent, because my child had his well check recently, and I got the freesia, paperwork the day before, was my son wasn't there when I was filling out all the paperwork, and the PHQ-9 was included in that. And what I've heard from parents and what I ended up doing was, you got to do it to get through it. So when parents come in, the first thing I ask is, who filled this out? And the mom's like, well, I did it, yesterday, my child wasn't there. A lot of them don't even actually tell you that if you don't ask them. And that's something that I learned because of my own experience, sadly. But I do then, go through all the questions individually. And I have noticed prior to when we were doing PHQ-9s prior to, the pandemic, parents were oftentimes more upset with us putting those in front of their kids. Now they're like, to your point, I think they're very appreciative most of the time. Like I used to get a lot, they don't like the fact that United doesn't pay for the PHQ-9. I just got my EOB. I'm like, really? But whatever, I don't care. I'm really, it makes no sense to me why they don't pay it. But they are appreciative. And so, but that is the one issue with freesia, and for it being sent out prior is just, you don't know who's filling it out. So I agree with you. Paper just seems to be a little bit better in terms of knowing exactly.
Right, I will agree. And I do have an issue because through Allied, we automatically get sent out the PSC, PSY the shorter screen, which first of all, I think is too short to really screen properly for anything. And second of all, the parents usually fill it out. So we do a separate teen screen, which I happen to like. One of my questions for Leah was, what screens do you recommend? I know we've had discussions about whether we should go to the PHQ-9, but then now they're talking about screening for anxiety, which the PHQ-9 does not screen for, and then the need for the separate suicide screen. So that was one of my questions.
Yeah, I agree. It is, I feel like the girls, so many more of them have anxiety, and I feel like, I'm having to actually, with the PHQ-9s, ask about, and there's so many, and, you have such a small period of time, and, you don't want to miss that or anything really, but so I agree. Thank you.
Right. I love the teen screen. I don't know if it's really, research proven, but I like that there's enough on there about depression and about anxiety. And then we do the separate suicide screen. So we're getting that more specifically. That's what I like, but I'd like to hear other people's opinions.
Okay.
Leah, you want to answer that question? What do you recommend for routine screening?
I think again that, the AAP is often, like if you look at Bright Futures, they don't often endorse a single thing, but sort of a menu. So I think you look in what you do as far as infants. I think moms, using the Edinburgh screen for depression. And I think it's really important that we do that screening. Of course, I like the Ages and Stages questionnaire for development. They do have the ASQ-SE for social emotional, which you can use. It's a little cumbersome. I don't know why they didn't do the scoring the same. It's weird. But those you have to pay for, obviously like the MChat. We started using the pediatric symptom checklist, which it's something that the parents can do for their kids, which is kind of nice because you're really trying to solicit, what are you worried about? And it gives you just a flavor of, that sounds like that could be, some anxiety or depression, as opposed to externalizing behaviors. And I think it's just a place for a conversation. And if it's all good, I think for younger kids, for the teenagers, the PHQ-9 plus a suicide screener, and we'll talk about that in a minute about why that's important. I like the GAD-7. It's quick and easy. I've used the Scared. There's another one called the Mask and RADS. Those are really great. I love them, but they're expensive and they're really time consuming. So, and then substance use screeners, I think the Craft, but again, you kind of got to pick and choose how you're going to do all that. You might not be using a formal substance use screener. You may be doing more surveillance, but you may pick up more using something like the Craft. So many things to choose from.
Yes. Herb, where are we on time? Are we looking to?
I think we're ready to transition to the second part.
Okay, I have one more question for Leah, okay?
Sure.
And you're gonna recognize this question, very important. All of this is talking about dealing with problems that exist, right? How do we detect them? Is there any movement on prevention, starting early, what we can do for our children so we're not in this place where suicide and gun violence are the #1 killers of children?
Whew. Yeah, and I would say from the, first of all, on the, thank you for the question, from the AAP perspective, and I am not speaking on behalf of the AAP, other than to say mental health has been a priority and will continue to be a priority. But I think there's a big, huge focus on relational health and how we can help our parents identify their kids' needs from an early age. And I do think that's why that maternal screening, speaking as a mom who had horrible postpartum anxiety, I just thought I was a bad mom for 6 months. I didn't know that there was a name for this and then I could have had help. And I think I would have been a better mom. My kids turned out okay, but that was hard. So I do think helping parents be parents. And I think this is where pediatricians are really good, because we have these relationships and can call out things like, wow, the way you looked at your baby just now, that was amazing. when you hold your baby like that, they know that you're there for them and you're responding to their needs. And when you see something on the response side, boy, that must be really frustrating when your child does blah, blah, blah. Have you tried this? Or what do you think about this? So I think that there are things we can do in that early infant mental health, early childhood stage. And I think that's absolutely where the gold is. So, I think there's a lot of information about relational health. I did a great podcast with Heather Forkey, who works a lot with children in foster care. She is amazing and lovely and talks about some really simple strategies. I also did one with Colleen Cullinan, who's a child psychologist that worked with me. She talks about the 5-minute golden hour, or the 5-minute golden rule, where for 5 minutes a day, a parent just focuses on that child and nothing else. 5 minutes. And you're not, correcting, commanding, you are just with your child playing, and building those kinds of strengths may be the answer. And then I think, again, is how do we make our home safe? I mean, I think we have to ask about, where are you storing your firearms? How do you store them? And not be afraid because people are going to get mad at us. I think this is now the #1 killer of kids, period. It just is. It's the only product in the United States that does not have safety regulations. So the other thing that we can do is advocate and vote. I mean, we just have to advocate for what kids need. I mean, I think, like to your point, Kristin, I mean, the insurance should pay for the screen. I mean, just pay for it. It saves so much down the road. When we're talking about adult health and ACEs, I mean, we all know about those things, but that's where the money is.
Okay, on that note, Herb, I will pass it back to you.
Well,
The panelists, if you want to go door.
Well, thank you, Kerry. I wanted to add something to what you just said before we go on to the next. And actually, I wanted to add 2 things. One is there's a wonderful book called The Optimistic Child, written by Dr. Gilham. And this is coming out of UPenn research on what they call positive psychology, or the science of well-being. And they have done phenomenal work in schools to change the trajectory of depressed and anxiety-ridden children. And they have a tool within the book on how to assess this. And they have very simple interventions, which they teach teachers, which then teach parents and the children. And it's all CBT-like. They call it the ABC. What's your adversity? What's your belief? What's the consequence? And that gives us great hope as to preventing, as opposed to building a whole new infrastructure to treat, which would be a colossal mistake that we have been repeating. Also, this is just my personal opinion, no one does a better job for the children of America than community-based pediatricians across the country. And they're doing it by the thousands. There's 60,000 of us. And many of us, or many of you, are going to the community-based office daily, and you're changing the life trajectory of these children. Sometimes all they need is a friend and someone to listen. And pediatricians are great at that. And pediatricians are the best doctors in the world because they raise the children that are the future of the world. And we often forget what a great job you're doing. So to all of you who have been in community pediatrics for many, many years, a great thank you to all of you, because you have changed the world one child at a time.